Chapter 51: Acute Kidney Injury and Chronic Kidney Disease. Kidney or renal failure is the partial or complete impairment of kidney function that results in an inability to excrete metabolic waste products in water and can affect all body systems. Treatment and dietary changes are challenging, and as it can impact lifestyle, occupation, family relationships, and self image. When comparing an AKI with a CKD, an acute kidney injury has a sudden onset, while chronic kidney disease is gradual over several years. The most common causes of an AKI are acute tubular necrosis, while in the case of chronic kidney disease, it's going to be diabetic neuropathy or hypertension. The diagnostic criteria is going to be an acute reduction in urine output or elevation in serum creatinine with an AKI. While a CKD, we're going to be monitoring that GFR or glomerular filtration rate. An AKI on the plus side is potentially reversible, while generally a CKD is not. Generally, these patients usually, the cause of death in the case of an AKI is going to be infection, while in chronic kidney disease, it's going to be cardiovascular related. An acute kidney injury. An AKI can range from slight deterioration to severe impairment, and a rapid loss of kidney function with a rise in serum creatinine or reduction in urine output. You may also see an elevated BUN or potassium. It has a high mortality rate and other life-threatening conditions. Here on figure 46-1 from the text, we just have the different causes of an acute kidney injury. On the left, we have that pre-renal causes, while in the middle, we have that intrarenal causes affecting the kidneys directly. Or in the case of on the right, we have that post-renal, where it's generally going to be an infection stemming from a UTI. The pre-renal factors are usually related to systemic circulation, causing a reduction in the renal blood flow, which leads to oliguria. This could go along with severe dehydration, heart failure, or even decreased cardiac output. Our intrarenal causes are usually related to direct damage to the kidney itself, such as prolonged ischemia, nephrotoxins, or the hemoglobin released by hemolyzed red blood cells, or even the myoglobin released from necrotic muscle cells. It may also be due to kidney diseases such as acute glomerulonephritis or lupus. Another intrarenal cause is acute tubular necrosis. This results from ischemia, nephrotoxins, or sepsis. In the case of severe ischemia, this causes disruption in the basement membrane and patchy destruction of the tubular epithelium. Nephrotoxic agents can cause necrosis of that tubular epithelial cells and clog the tubules. For postrenal causes, it could be everything from mechanical obstruction of the outflow, which results in a reflux into the renal pelvis, impairing kidney function. It could also be benign prostatic hyperplasia, prostate cancer, renal calculi, trauma, or extrarenal tumors. Three phases are oliguric, diuretic, and recovery. There's also the rifle classification, which is risk, injury, failure, loss, and end-stage renal disease. In the oliguric phase, there is urinary changes, and this would be a urine output of less than 400 milliliters a day. And it often occurs within 1 to 7 days after the injury and can last up to 10 to 14 days, even longer, though that does have a poorer prognosis. During the oliguric phase, hypovolemia may exacerbate the AKI. You may also see decreased urine output leading to fluid retention. This will go along with neck vein distension, bounding pulse, edema, and hypertension. It may also result in metabolic acidosis. The impaired kidney cannot excrete hydrogen ions or the acid products of metabolism. Serum bicarbonate production is also decreased, further exacerbating the issue. During a sodium balance, there's going to be an increased excretion of sodium due to the damaged tubules. That hyponatremia can lead to cerebral edema. Potassium excess could also be a result from the impaired ability of the kidneys to excrete potassium, and an increased risk with massive tissue trauma where further potassium is released. It's usually asymptomatic, though ECG changes can present, such as peak T waves, widened QRS complex, or ST depression. In the oliguric phase, hematologic problems may also present, such as leukocytosis due to an infection that may be fatal. This would also correspond with urinary and respiratory tract infections. There could also be waste product accumulations, such as BUN and serum creatinine levels. In the diuretic phase, the daily urine output is 1 to 3 liters, though it could be up to 5 liters. Osmotic diuresis from high urea and an inability of the tubules to concentrate our urine. We need to monitor for hypovolemia, hypotension, hyponatremia, hypokalemia, and dehydration. Other diagnostic studies would include a thorough history, a serum creatinine and electrolytes, urinalysis, a renal ultrasound, renal scan, CT scan, and a renal biopsy. There's going to be many considerations for an AKI, especially pertaining to diagnostic studies that involve contrast dye, as that contrast dye is processed in the kidneys. And we give a patient that contrast dye with a kidney that's unable to handle it, it could be potentially fatal. And we'd also need to be considering things like diabetics taking metformin. Metformin is another nephrotoxic drug that is processed in the kidneys, and we need to hold that for 48 hours before and after the use of a contrast medium. If the contrast is needed for high risk patients, we're going to use low dose and optimal hydration. And if this patient is on dialysis, especially in the case of CKD, we're going to send that patient to dialysis immediately after. In the case of interprofessional care, we're going to eliminate the cause, manage the signs and symptoms, and prevent complications. We want to ensure adequate intravascular volume and cardiac output. This would be provided with things like loop diuretics, osmotic diuretics, and closely monitor the fluid intake during that oliguric phase. A general rule of thumb is that we want to keep AKIs wet. You want to keep an acute kidney wet. You want a lot of fluid on there because we want to give that kidney every chance it can to recover. It's not until you get to chronic kidney disease that we're going to be restricting fluid, because in the case of chronic kidney disease, that kidney is not coming back, and we do not need that excess fluid within the patient that they're unable to excrete. In the case of hyperkalemia therapies, there's going to be a temporary move of the potassium into the cells. This could be a result of things like insulin and sodium bicarbonate. We also want to watch to decrease dysrhythmias and stabilize the patient, using everything from calcium gluconate if necessary. And finally, we want to work to remove that excess potassium from the body with things like Kxalate or dialysis. The indications for renal replacement therapy are volume overload, elevated serum potassium level, metabolic acidosis, a BUN over 120, significant changes in metal status, pericarditis, pericardial effusion, or cardiac tamponade, and further assessing the clinical status of the patient. Renal replacement therapy can take many different forms, each having their own benefits and pros and cons to each treatment. In the case of peritoneal dialysis, in this case, the patient would use dialysate inserted into their abdomen. And it does have the major benefit that it can be done at home, though it does also come with a significant risk of infection. There could also be intermittent hemodialysis, which may be what you're more familiar with dialysis facilities where the patients come 3 days a week. You could also see in emergent situations in the hospital continuous renal replacement therapy. Nutritional therapy is going to be key, where we want to maintain an adequate caloric intake, primarily carbohydrates and increased fat, and also adequate protein to prevent breakdown. Furthermore, we want to restrict sodium, potassium, and phosphate, as these are excreted by the kidney, and provide calcium supplements or phosphate binding agents to prevent the buildup of phosphate. For our nursing assessment, we want to measure vital signs, provide daily weights, provide a strict intake and output, examine the urine, assess the general appearance, and observe the dialysis access site. For our nursing assessment, we want to assess their mental status, level of consciousness, along with their oral mucosa, lung sounds, heart rhythm, laboratory values, and other diagnostic test results. Our nursing diagnoses would include electrolyte imbalances, fluid imbalances, risk for infection, or anxiety. When planning, the patient with an AKI will completely recover without any loss of kidney function, maintain normal fluid and electrolyte balance, have decreased anxiety, and adhere to and understand the need for careful follow-up care. Health promotion is going to focus on things like prevention and early recognition. We want to identify and monitor all high-risk populations, control their exposure to nephrotoxic drugs and industrial chemicals, and prevent prolonged episodes of hypotension and hypovolemia. For health promotion, we want to monitor daily weights, including intake and output, along with their fluid and electrolyte balance, replace significant fluid losses, provide aggressive diuretic therapy for fluid overload, and use nephrotoxic drugs sparingly while monitoring their renal function. In the case of acute care, we're going to obtain accurate intake and output. Daily weights will be key. Also, assessing for hypovolemia or hypovolemia, watching for potassium and sodium disturbances, meticulous aseptic care, careful use of nephrotoxic drugs, and thorough skincare measures along with mouth care. In ambulatory care, we want to monitor that kidney function, regulate their protein and potassium intake, provide follow up care, teaching, and any appropriate referrals. During evaluation, the expected outcomes are that the patient with AKI will regain and maintain normal fluid and electrolyte balance, adhere to the treatment regimen, have no complications, and have a complete recovery. Other gerontologic considerations include a decreased GFR with aging. These patients are more susceptible to an AKI, including dehydration, and also from the effects of things like polypharmacy with diuretics, laxatives, illness, and immobility. This all could combine for hypotension, also a decreased ability to recover should an injury happen. Let's move on to chronic kidney disease. Chronic kidney disease is a progressive, irreversible loss of kidney function. It occurs in greater than 26 million American adults and is more common than AKI. It also has an increased prevalence related to an aging population, increased obesity, increased diabetes, and increased hypertension. Over 500,000 Americans are facing treatment for end stage renal disease right now, and unfortunately, it does have a high mortality rate. Kidney disease has improving global outcomes, and it defines CKD as kidney damage, with pathological abnormalities and markers of damage from blood, urine, and imaging tests. For chronic kidney disease, the leading cause is diabetes at 50% of cases, with hypertension coming in second at 25% of cases. Finally, the other causes could be glomerular nephritis, cystic diseases, and urologic diseases. Persons with chronic kidney disease are often asymptomatic, with up to 70% unaware. Here on figure 46-7 from the textbook, we have the stages of chronic kidney disease. It begins with stage 1 with a GFR over 90. As you can see, as the GFR decreases, more aggressive treatments and interventions are required. For chronic kidney disease, Medicare covers 80% of the cost, as it is considered a disability. Other clinical manifestations are the result of retained substances that the damaged kidney is unable to excrete, such as urea, creatinine, phenols, hormones, electrolytes, water, and uremia. In the case of uremia, this is a syndrome in which kidney function declines to the point that the symptoms occur in multiple body systems. Often occurs when the GFR is less than or equal to 15 milliliters a minute, and the manifestations vary depending on the cause, comorbidities, age, and adherence to the medical regimen. Clinical manifestations of chronic kidney disease can be severe, everything from psychologic and neurologic disturbances to cardiovascular, GI, pulmonary, endocrine, metabolic, and musculoskeletal, just to name a few. For clinical manifestations, in the early stages, there are no changes in urine output. In the case of polyuria, they may be present related to diabetes. Though as that CKD progresses, there is increasing fluid retention and the need for diuretics and dialysis. After a period on dialysis, the patients may become anuric, meaning they no longer produce urine. The waste product accumulation, as the GFR decreases, BUN and serum creatinine levels increase. This results from kidney failure and protein intake, along with fever, corticosteroids, and catabolism. It can be further present with nausea, vomiting, lethargy, fatigue, impaired thought processes, and headaches. In the case of altered carbohydrate metabolism, this is caused by impaired glucose metabolism. It could be from cellular insensitivity to normal action of insulin. It could also be mild to moderate hyperglycemia and hyperinsulinemia. In the case of defective carbohydrate metabolism, patients with diabetes who develop uremia may require less insulin than before the onset of chronic kidney disease. The excretion of insulin dependent on kidneys, as well as the insulin dosing, must be individualized and may improve after starting dialysis. In the case of elevated triglycerides, hyperinsulinemia stimulates hepatic production of triglycerides. This could also result in altered lipid metabolism, meaning decreased levels of the enzyme lipoprotein lipase, which is important to breakdown of lipoproteins. While chronic kidney disease can result in an elevation of a wide variety of electrolytes, potassium is going to be your top priority to assess due to its effect on the heart. Hyperkalemia is the most serious electrolyte disorder in kidney disease and can result in fatal dysrhythmias. It's when the serum potassium level reaches 7 to 8 that it could be potentially fatal. The decreased excretion, breakdown of cellular protein, bleeding, and metabolic acidosis all further contribute to this increased potassium. Sodium levels may be high, low, or normal. The impaired excretion causes sodium and water retention. There also may be a dilutional effect, such as from edema, hypertension, and heart failure. It can also have clinical manifestations on electrolytes like calcium, phosphate, and magnesium. Phosphate is going to be especially key as these patients are going to be on a phosphate binder so that every time when they eat their meals, they take a phosphate binder. Because otherwise, the major danger is that phosphate builds up in the extremities. It can build up in the tips of the fingers, build up in the tips of the toes, and actually turn into a stone and fall off. As we've discussed, metabolic acidosis could come from impaired ability of the kidneys to excrete excess acid, also defective reabsorption and regeneration of bicarbonate. Anemia may also result, and this is due to the decreased production of erythropoietin. Erythropoietin is a hormone produced in the kidneys that stimulates the red blood cell production from your long bones. In the case of renal failure, that kidney is no longer producing that hormone to stimulate red blood cell production. These patients may also present with bleeding tendencies due to a defect in platelet function, as well as infection resulting from the changes in white blood cell function, altered immune response and function, and hyperglycemia, along with external trauma. Cardiovascular disease and chronic kidney disease are closely linked, and death is often related to an MI, ischemic heart disease, peripheral artery disease, heart failure, cardiomyopathies, or stroke. Calcium deposits may also be associated with the stiffness of blood vessels and the vascular smooth muscle cell changes. There could also be high calcium and phosphate totals, impaired renal excretion, and drug therapies to treat bone disease. Hypertension is both a cause and consequence of chronic kidney disease. It's aggravated by sodium and water retention, as well as the increased renin production that may contribute. Blood pressure control is one of the most important goals, along with dysrhythmias like hyperkalemia and a decreased coronary artery perfusion. The uremic pericarditis can progress to effusion and tamponade. Patient may also see Kussmaul respirations related to acidosis. In this case, dyspnea may occur with fluid overload, pulmonary edema, uremic pleuritis, pleural effusions, and respiratory infections. Every part of the GI system is affected, causing excessive urea. Could also be presenting with stomatitis with exudates and ulcerations, uremic fever or a urinous odor on the breath, anorexia, nausea, vomiting, diabetic gastroparesis, GI bleeding, and constipation. Other expected results of kidney disease are increased nitrogen waste products, electrolyte imbalances, metabolic acidosis, and atrophy, along with demyelination of the nerve fibers. The patient may also present with CNS depression, including lethargy, apathy, a decreased ability to concentrate, fatigue, irritability, altered mental ability, seizures, coma, and a hypertensive encephalopathy. In the case of peripheral neuropathy, there could be restless leg syndrome, paresthesias, and further motor involvement such as foot drop, muscle weakness and atrophy, loss of deep tendon reflexes, along with muscle twitching, jerking, asterixis, and nocturnal leg cramps. In the case of chronic kidney disease, mineral and bone disorders, this is a systemic disorder of the mineral and bone metabolism that results in a weakening of the skeletal bones, such as osteomalacia, and a soft tissue complication, such as vascular calcifications. Here in figure 46-3 from the text, we just have the mechanisms of chronic kidney disease, mineral and bone disorder, and how it progresses through the body. The patient may also present with pruritus. This is due to the calcium and phosphate deposits, along with sensory neuropathy. The itching may be intense and even lead to bleeding or infection. The patient should be taught to scratch with their knuckles, not with their fingernails, which is a common question. Even more concerning, the patient may present with uremic frost, and this is where the urea crystallizes on the skin. As the body is unable to produce urine, The body is attempting to excrete some of that waste out through the sweat glands, resulting in that uremic frost. The patient may also experience infertility and decreased libido, sexual dysfunction, and pregnancy during dialysis poses significant risk to both the mother and the infant. Patient may also present with personality and behavioral changes, emotional lability, withdrawal, and going along with anxiety, depression, and grief. Our diagnostic studies would include a history and physical examination, a dipstick evaluation of protein, albuminuria, urinalysis, renal ultrasound scans, a CT scan, though again, be very cautious with any contrast dyes. For interprofessional care, our overall goals are to preserve existing kidney function, reduce the risks of cardiovascular disease, prevent complications, and provide for the patient's comfort. Our management, especially in the stages of 1 to 4, are going to be to control the hypertension, hyperparathyroid disease, anemia, and dyslipidemia. Also, to carefully correct any fluid volume overloads or deficits. Our drug therapy is going to focus on hyperkalemia, as well as the restriction of high potassium foods and drugs. And in the acute cases, IV glucose and insulin to actually force that excess potassium back into the cells so that it can be slowly excreted and managed. Other treatments for hyperkalemia may include a drug called Kxalate, which binds with the potassium within the GI tract, though dialysis is far and away the most effective treatment. When treating the hypertension, weight loss is going to be your first treatment if needed. There could also be therapeutic lifestyle changes, implementing the DASH diet, and antihypertensive drugs, though the patients will often need 2 or more. If a diabetic, give ACE inhibitors and ARBs in combination. When dealing with CKD mineral and bone disease, phosphate should not be restricted until the patient requires renal replacement therapy. Then the phosphate intake is then restricted to less than 1 gram per day. To prevent the buildup of phosphate, the patient may be getting phosphate binders, which are most commonly drugs such as Foslo or Caltrate. These phosphate binders should be administered with each meal, but keep in mind a side effect is constipation. While receiving this treatment, we also want to avoid aluminum and magnesium preparations. Provide supplemental vitamin D, such as cholecalciferol, and the serum phosphate level must be lowered before the calcium or vitamin D is administered. Control the secondary hyperparathyroidism. Remember that parathyroid is very key in the processing of calcium within the body. And we're going to have drugs such as Sensipar that increase the sensitivity of calcium receptors within the parathyroid glands. We spoke previously about the anemia secondary to the lack of the hormone erythropoietin produced by the kidneys, which is no longer stimulating the long bones to produce red blood cells. In this case, we're going to supplement that hormone with drugs such as Epogen or Procrit. The patient may also receive iron supplementations if the plasma ferritin level is less than 100. Side effects, though, would include gastric irritation, constipation, and making the stool dark in color. They may also receive folic acid supplements, which is needed for red blood cell formation and is unfortunately removed by the dialysis treatment. In the case of dyslipidemia, the patient may be placed on statins, which is most effective at lowering the LDL level, with drugs such as atorvastatin or Lipitor. Also, be very aware of drug toxicity risks with drugs such as digoxin, diabetic agents, antibiotics, and opioids, as the drug doses and frequency may need to be adjusted depending on the severity of the CKD. For nutritional therapy, it's designed to maintain good nutrition, improve protein intake, and provide fluid restriction with hemodialysis. That intake is going to depend on the patient's daily urine output. The patient may also be on a sodium restriction, with diets varying from 2 to 4 grams a day. We want to avoid any high sodium foods wherever possible, and provide salt substitutes that should be avoided because they contain potassium chloride. So we want to be very careful with any electrolyte we give this patient. Potassium restriction will be limited to 2 to 3 grams daily, and high potassium foods should be avoided, especially in the case of patients on hemodialysis, as they only get treatments 3 days a week. That is their only time to have that excess potassium removed. In the case of phosphate restriction in end-stage renal disease, we're going to limit it to 1 gram per day. And foods high in phosphate include meat and dairy products. So while we're not going to completely restrict that from the diet, we're definitely going to make sure these patients are taking their binder whenever these food products are present. Our assessment is going to involve a complete history with any existing kidney disease or family history. It'll also involve long-term health problems and medications, both prescribed, over-the-counter, and herbal supplements the patient may be taking. Our overall goals are to show the knowledge of and ability to adhere with the therapeutic plan, participate in the decision making for the plan of care and future treatments, as well as having effective coping strategies. For health promotion, we want to identify people at risk for chronic kidney disease, including diabetes, hypertension, a history or family history of kidney disease, as well as repeated urinary tract infections. In the acute care, most care for chronic kidney disease occurs as an outpatient, and the in hospital care required for management of complications and for kidney transplantation. In the case of ambulatory care, we're going to focus on diet with regular visits with the dietitian, as well as assessing for drugs such as common side effects, a pill organizer, and avoiding over the counter drugs. Make sure they're taking their blood pressure daily and identify any signs of fluid overload and electrolyte imbalances. In the ambulatory setting, the patient can also complete their evaluation for a kidney transplant and explain what is involved in peripheral dialysis, hemodialysis, home dialysis modalities, transplantation, and palliative care. There's going to be a lot of different options the patient has at their disposal for treating this condition. For outcomes, the patient with CKD will maintain fluid and electrolyte levels within normal ranges and an acceptable weight with no more than 10% weight loss. Let's talk about dialysis. Dialysis at its core is the movement of fluid molecules across a semi-permeable membrane from one compartment to another, and it's used to correct fluid and electrolyte balances and remove waste products in kidney failure. It can also be used to treat drug overdoses. Your two most common types of dialysis are going to be peritoneal dialysis and hemodialysis. It started when a patient's uremia can no longer be adequately treated conservatively, and the GFR has reached below 15. Nephrologists determine when to start, and uremic complications do require dialysis. Unfortunately, end-stage renal disease is still treated with dialysis because there is a lack of donated organs. Some patients are physically or mentally unsuitable for transplantation, and some patients just do not want transplants. Dialysis works on the general principle of diffusion. That is the movement of solutes from an area of greater concentration to an area of lesser concentration. Here in figure 46-4, we have the osmosis and diffusion across the semipermeable membrane. Osmosis, on the other hand, is the movement of fluid from an area of lesser concentration of solutes to an area of greater concentration, such as glucose in dialysate that creates an osmotic gradient to pull fluid from the blood. During dialysis, the patient may also receive a procedure known as ultrafiltration, and in this case, water and fluid only is removed from the patient. And this results when there's an osmotic gradient of pressure across that membrane. In the case of peritoneal dialysis, it's the glucose in the dialysate, while in hemodialysis, it's the pressure gradient or the pressure applied to the dialysate. Peritoneal access is obtained by inserting a catheter through anterior abdominal wall. The technique for catheter placement varies, though is usually done via surgery. Peritoneal dialysis may start right away or be delayed until the site is healed. Aseptic techniques are important to avoid infection and eventual peritonitis. Here in figure 46-5, we just have a diagram showing how that peritoneal dialysis is accomplished by that catheter inserted into the abdomen. The dialysate is instilled, and then when it's removed, is actually filtered through that peritoneum into the drainage bag. And here in 46-6, we just have a picture of that catheter. There are three phases of the peritoneal dialysis cycle. The inflow or the fill, where 2 to 3 liters of dialysate are instilled, the dwell time of 20 to 30 minutes up to 8 hours, and then the drainage time. From there, the cycle is repeated. It's called an exchange, and the volume depends on the size of the peritoneal cavity. In automated peritoneal dialysis, a cycler delivers the dialysate during sleep times and controls the fill, dwell, and drain phases. There are also alarms and monitors involved for the patient's safety. On the other hand, there's also the continuous ambulatory peritoneal dialysis, where a manual exchange is accomplished 4 times a day. Here's just a picture showing the automated peritoneal dialysis machine. We want to be very alert for complications, especially for any indication of infection, such as redness, tenderness, drainage, and make sure we're very prompt when treating those with antibiotics. In the case of peritonitis, we're going to have exit site or tunnel infection. This would be indicated by abdominal pain, rebound tenderness, or cloudiness with white blood cells or bacteria within the drained dialysate. They may also present with GI symptoms such as diarrhea, vomiting, distension, and increased bowel sounds. We're going to want to treat these with antibiotics, and repeated infections may cause adhesions. Other complications would include hernias, such as increased intra-abdominal pressure from the dialysate, lower back problems, bleeding, pulmonary complications, and protein loss. Bleeding may be common with initial catheter placement, especially in the case of new, active intraperitoneal bleeding. Check that blood pressure and hematocrit closely. For pulmonary complications, this is going to be due to decreased lung expansion due to the volume being taken up by the dialysate. Peritoneal dialysis can be very effective. It has a short training program of only 3 to 7 days. And the advantages are its simplicity. It's being able to be done at home. Has an increasing patient participation, no need for special water systems, and the equipment setup's relatively simple. On the other hand, hemodialysis requires rapid blood flow and access to a large blood vessel. Obtaining vascular access is one of the most difficult problems, and it can be everything from arterial fistulas and grafts to a temporary vascular access, such as a catheter. Fistulas and grafts are created in the forearm or upper arm, where is the preferred access site for hemodialysis. The fistula allows the arterial blood to flow through the vein and becomes arterialized. Increased vein size and wall thickness goes a long way. They're placed 3 months before hemodialysis so that they have a chance to mature. And again, when we're assessing it, we want to assess that every single shift, every time we see that patient. We're going to hear the bruit and feel the thrill. Here we just have a diagram showing how that fistula would bridge the artery and vein to create an access point for the hemodialysis machine. And here's a great picture showing the artery and vein that they're going to connect. An arterial graft is a synthetic material surgically placed under the skin to form a bridge between that artery and vein. The healing time is 2 to 4 weeks, and it's more likely to get infected or form clots. If infected, it may need to be removed. And here's just a diagram showing how that graft is placed underneath the skin and connects the artery to the vein. Hero grafts, or hemodialysis reliable outflow, these are special bridge accesses used when other access options are exhausted. It comes in 2 pieces, a reinforced tube to bypass blockages. In this case, the dialysis graft is placed into the artery, placed under the skin, and it bypasses the venous system and allows the blood to flow from the target artery straight to the heart. And here's just a better diagram showing you how that hero graft is installed. Other risks include distal ischemia or Steele syndrome. In this case, we're diverting way too much blood, and they start getting pain distal to the access site, numbness or tingling of the fingers, and poor capillary refill. There's also a safety alert for these fistulas and grafts. There's no blood pressures, venous punctures, or IV lines anywhere in that arm. For temporary vascular access, they could insert a catheter. A major central line is going to be a tunnel double lumen that can be used for both blood removal and blood return. Unfortunately, these catheters also have the high risk for infection, those CLABSIs we've previously discussed, as well as dislodgement and malfunction. Fun story, I actually had a patient come back in and had duct taped his dialysis catheter down once. And here's just a picture of that double lumen vascular catheter. And here's another diagram showing how that catheter is inserted and gains vascular access. And finally, here's a picture of a patient receiving dialysis through that catheter. Long-term cuffed catheters are used when waiting for fistula or graft access to mature. Exit on the upper chest and are tunneled to internal or external jugular vein. Here's a picture of that long-term cuffed catheter. The dialyzer, where the exchange takes place, and that is that big plastic cartridge you'll see hanging up on the top of the dialysis machine on that metal pole on that arm. It's a plastic cartridge that contains thousands of parallel hollow tubes or fibers that are the semi-permeable membrane. Blood is pumped from the top into the fibers, and the dialysate is pumped from the bottom outside of those tubes, and that's where the exchange takes place. When the blood reaches the end, it's returned via a single tube to the patient. Before hemodialysis treatment, assess the patient's fluid status, including weight, blood pressure, peripheral edema, and heart and lung sounds. We're also going to want to assess the weight from the last post dialysis and current weight pre dialysis to determine how much fluid will be removed. Assess the vascular access, assess the temperature, and monitor the vital signs every 30 to 60 minutes. In traditional dialysis, by that fistula or graft, two large bore needles are placed. One needle is used to pull the blood from the circulation into the dialysis machine, and the other needle is used to return the dialyzed blood to the patient. Heparin is also added to prevent clotting within the machine. For the components of hemodialysis, here we just got a diagram showing the blood pump as it's pulled from the patient, run through the dialyzer with that dialysate flowing outside of those hollow straws inside of the dialyzer. And once that blood has the waste products removed as well as the excess fluid, it's then returned to the patient. The dialyzer blood lines are primed with saline solution to eliminate air. They're also terminated by flushing with saline to return all the blood to the patient. The needles are then removed and firm pressure is applied to stop the bleeding. Most are treated in community-based centers, dialyzed for 3 to 4 hours, 3 days a week. Other schedule options include short daily hemodialysis, long nocturnal hemodialysis, or home hemodialysis. For hemodialysis complications, hypotension, because again, we're taking up to 400 milliliters of blood out of the patient to run through the machine. We're also going to be removing a large amount of fluid during that treatment. So the patient is not getting as much volume back as we have taken out. Hypotension is going to be a very major consideration. They may also have issues with muscle cramps, again, due to the hypovolemia. The patient will unfortunately also lose some blood during treatment. This is due to blood not rinsed from the dialyzer, the accidental separation of tubing, dialysis membrane rupture, or bleeding after the needles are removed, especially due to the heparin or if the patient's also taking Coumadin or other blood thinners on the side as well. Hepatitis is another major risk. Fun fact for dialysis, HIV patients can actually dialyze on a machine right beside another patient because HIV does not live on surfaces for very long. Whereas hepatitis B, on the other hand, hepatitis B virus can live on a surface for 30 days. Those patients are going to go to an isolation room and dialyze on their own. Hemodialysis cannot fully replace the normal function of kidneys. Think of it that they have kidney function 3 days a week during their treatment, and that's it. It can ease many of the symptoms, though. A lot of patients can go on to live a long, full life, getting their 3 treatments a week. We'll even set up treatments for patients when they go on vacation. For hemodialysis effectiveness, it's an individual adaptation. It could be positive, ambivalent, or depressed. For continuous renal replacement therapy, this is a method for treating AKI. It's a means by which the uremic toxins and fluids are removed. Also, the acid-base status and electrolytes are adjusted slowly and continuously in a hemodynamically unstable patient. It does have a contraindication, however, and that is if the patient has a life-threatening manifestation of uremia that requires rapid treatment. There's going to be many different types of continuous renal replacement therapy: slow continuous ultrafiltration, continuous veno-venous hemodialysis, just to name a few. And here's just a diagram of that continuous veno-venous therapies, and it has a very similar process to the hemodialysis we previously discussed. For continuous renal replacement therapy, it's an infusion of replacement fluids determined by the degree of fluid and electrolyte imbalance. Anticoagulants are needed to prevent the blood clotting in the machine, and it's customized to each patient's needs. These forms also use dialysate, and the dialysis fluid is attached at the distal end of the hemofilter. In this case, the blood is pumped slower than hemodialysis, and it's continuous rather than intermittent, which can make it less jarring for the patient. The fluid volume can be removed over days versus hours in that short outpatient hemodialysis treatment. For continuous renal replacement therapy versus hemodialysis, it does not require constant monitoring by a hemodialysis nurse, just needs the ICU nurse present, and also does not require complicated hemodialysis equipment. It can be continued as long as 30 to 40 days, and the hemofilter should be changed every 24 to 48 hours, however. They're able to obtain specimens, and the ultrafiltration should be clear to yellow. If it's bloody, we need to terminate. For our specific nursing interventions, we need to obtain weights, monitor and document the laboratory values daily for fluid and electrolyte balance, assess hourly intake and output, vital signs, and a hemodynamic status, and care for the site to prevent infection. Next, we have a wearable artificial kidney. It's recently developed and approved for use. It's a miniaturized dialysis machine weighing about 10 pounds, and the carrier resembles a tool belt. It connects to the patient via catheter and is designed to filter the blood in end-stage renal disease and can run continuously on batteries. Next, let's talk about kidney transplants. There are more than 100,000 patients currently waiting for kidney transplants, with an average wait time for a cadaver kidney being 2 to 5 years. There are 17,000 transplants that take place every year, and the advances include organ procurement and preservation, surgical techniques, tissue typing and matching, immunosuppressant therapy, and the prevention and treatment of graft rejection. A kidney transplant is the best treatment of end-stage renal disease and can be very successful. A 1-year graft survival rate with a deceased donor transplant is 90%, and a live donor transplant is 95%. This reverses the pathophysiology of end-stage renal disease. It also eliminates the need for dialysis and dietary and lifestyle restrictions. In the long run, it's also less expensive than dialysis after the first year. Candidates are determined by a variety of medical and psychosocial factors that vary among transplant centers, with possible exclusions including obesity and a smoker. A preemptive transplant, that is before dialysis required, is possible if the recipient is a living donor. Contraindications to transplant include advanced cancer, refractory or untreated heart disease, chronic respiratory failure, extensive vascular disease, chronic infections, though keep in mind HIV or hepatitis B or C are not contraindications, however. Surgical procedures may be required before transplant and include coronary artery bypass or coronary angioplasty, cholecystectomy, and a bilateral nephrectomy. For kidney transplant histocompatibility studies, the purpose of testing is to identify antigens for both donors and potential recipients to greatly improve its odds of a successful transplant. Kidney transplant donor sources include deceased donors with compatible blood type, blood relatives, emotionally related living donors, altruistic living donors, or paired organ donation. In the case of a live donor, there is extensive interprofessional evaluation, including cross matches to check the antibodies. The advantages are a better patient and graft survival rates, immediate organ availability, immediate function with minimal cold time, and the opportunity to have the recipient in best possible medical condition, since it is an elective surgery. The live donor sees the nephrologist for a thorough history and physical, including laboratory studies like a 24-hour urine with creatinine clearance and total protein, a complete blood count, chemistry, and electrolyte profiles. This would be in addition to hepatitis B and C, HIV, and CMV testing, cytomegalovirus. Diagnostic studies include an ECG and chest x-ray, along with a renal ultrasound, arteriogram, and the psychologist or social worker evaluation based on their emotional stability, risks and benefits, the cost covered by the recipient's insurance, and the no compensation for lost wages. This would go with a paired organ donation, an ABO incompatibility between the donor and the recipient. They would find another donor recipient pair with whom to exchange kidneys so that everyone finds a match. In the case of a deceased cadaver kidney, donors are relatively healthy persons who have suffered an irreversible brain injury and are brain dead. The patient must have effective cardiovascular functions and on a ventilator to preserve the organs. They must also have the permission of the next of kin requested, even with a signed donor card. The kidneys are then removed and preserved up to 72 hours. The preferred cold time, however, is less than 24 hours. In the case of a live donor, the donor nephrectomy is performed by a transplant surgeon. It begins 1 or 2 hours before the recipient's surgery is started, and the recipient is surgically prepared in a nearby operating room. In the case of a live donor, there is a laparoscopic donor nephrectomy, the most common approach for removing a kidney in a living donor. It's minimally invasive with fewer risks and a shorter recovery time. It has an open conventional nephrectomy, which has a lateral incision, and a rib may need to be removed. In the case of a kidney transplant recipient, the transplanted kidney usually is placed extraperitoneal in the iliac fossa. The right iliac fossa is preferred for anastomosis of the blood vessels and ureter. Here we just have a diagram showing that transplanted kidney above that iliac crest in the incision that they would make. Before the incision, a urinary catheter would be placed into the bladder. Antibiotic solution would then be instilled. This works to distend the bladder and decrease the risk of infection. In the case of a kidney transplant recipient, rapid revascularization is critical. The donor artery anastomose to the recipient internal or external iliac artery. The donor vein is anastomosed to the recipient external iliac vein. For the kidney transplant recipient, when the anastomoses are complete, the clamps are released and blood flow is reestablished. Urine may begin to flow from the ureter immediately. The donor ureter is then tunneled through the bladder submucosa. Under preoperative care, be aware of the stress that dialysis may be required. Review for any immunosuppressive drugs and the prevention of infection, in addition to an ECG, chest x ray, laboratory studies, and dialysis if needed. For the postoperative care, we're going to closely monitor the patient's renal function with an accurate I's and O's. Also, closely monitor the hematocrit. The donors usually experience more pain than the recipient, unfortunately, and acknowledge their gift. Maintenance of fluid and electrolyte balance is the first priority. Large volumes of urine may be reduced soon after the transplanted kidney due to the new kidney's ability to filter BU in, the abundance of fluids during operation, and that initial renal tubular dysfunction. Under postoperative care, dehydration must be avoided. We want to assess for hyponatremia and hypokalemia closely, including acute tubular necrosis that can occur, and monitor the urine output while maintaining catheter patency. Also, patient education, signs and symptoms of rejection, infection, and any surgical complications must all be assessed for. The goals are to adequately suppress the immune response to prevent rejection, also to maintain sufficient immunity to prevent overwhelming infection. Rejection is something the patient's going to need to be aware of for the rest of their life. It could occur minutes to hours after transplant, or even up to days, months, or years after transplant. And this patient will be on anti rejection meds for the rest of their life. In the case of infection, this risk is related to the suppression of the normal defense mechanisms. We're purposely suppressing that immune system to stop it from attacking that transplanted organ. Unfortunately, this also places the patient at a much higher risk of infection. Some of our opportunistic fungal infections include Candida, Cryptococcus, Aspergillus, or Pneumocystis jirovecii. Viral infections, and one of the most common and deadly, is cytomegalovirus, CMV. This is actually a virus that most of us are exposed to every day. Unfortunately, it's once they have an immune system, this virus can pose a major danger to organ transplant patients. Other dangerous viruses could be Epstein-Barr, herpes simplex virus, varicella zoster, or polymyrovirus or BK virus. In the case of cardiovascular disease, transplant recipients have an increased risk of atherosclerotic vascular disease. Immunosuppressants can worsen hypertension and hyperlipidemia, and the patients need to adhere to antihypertensive regimen. Cancers are going to be another major danger due to the immunosuppressive therapy. Most common include skin cancers, lymphatic lymphoproliferative disorders. Regular screening is going to be key here, as well as protective clothing and sunscreen. Another major danger is going to be the reoccurrence of that original kidney disease, including glomerular nephritis, IgA nephropathy, diabetic nephropathy, or a focal segmental sclerosis. And finally, corticosteroid related complications. Due to the aseptic necrosis of the hips, knees, and other joints, peptic ulcer disease, diabetes, cataracts, dyslipidemia, infections, and cancers. Yeah, as someone who's worked both renal dialysis, hemodialysis, as well as kidney transplant, kidney failure is no joke. It's same time what they can do with kidney transplants is nothing short of amazing. It's come a long, long way over the last decades. They can have a healthy patient in and out in a very much quicker than you would think. But anyway, that's all we got for this chapter. I'll see you in the next slides.